Thank you for joining us. And I think we're going to have questions across all the panelists. So please raise your hand and we'll have this thrown at you to speak up into the mic.
So in the advent of precision data collection and having a system where it's very financially viable to commercially nudge consumers, so how do you financially incentivize the transparency of the dissemination or the data collection to ensure privacy or ethical curation of that data?
So in terms of the collection of the data you're talking about, I'm not sure I fully understand your question. Now that the microphone's disappeared, sorry.
So if you're collecting a lot of data on everyone in certain ways, and the point is to ethically nudge people into better health practices, but how do you financially incentivize the industries around it to, keep that data safe? Or even if you're building more precise models that you don't make publicly available, you might actually just have ways to get more information that you don't want to share initially that doesn't actually nudge patients or people into the better direction.
Sure, yeah, and I think I was a little fast in my summary, so I didn't go over all the details. And these data are obviously collected under a certain use agreement. At the time of model building, for the most part, they're made available through some partnership that is agrees with those terms of use, which does not usually require individual consent for that particular application. However, when you go to turn it around in a prediction mode and use it with consumers, of course, at that point, they would need to have an informed consent to participate in that process so they know what they're getting into. So the data in that sense are held, I think, according to ethical standards and usual security standards. The financial question is a different one, and I think this is kind of the challenge. I painted this kind of wonderful scenario where it's profit positive or at least neutral for the company, and it's health positive for the consumer. We don't know if that space exists, to be honest. We'd like to think it does, but it's open to study, I think.
I think we should have Virginia also respond to that.
Yeah, so it's really interesting that you raised this story, because one of the ways that I came to the work that I do is actually, so I come from a background in the community technology center movement and welfare rights and economic justice movements, and one of the kinds of work that I did for many years was build sort of technical resources in poor and working class communities in collaboration with folks who lived in those communities. And one of the places I did that was at a residential YWCA in Troy, New York, which is my hometown. And one of the folks I worked with, who goes by a pseudonym in my work because she was part of some academic research many years ago, but she goes by the pseudonym Dorothy Allen in my work, was somebody who had helped design one of these spaces. And we were sort of sitting around in this space one morning just kind of shooting the breeze about technology. And I had asked her about her EBT card, her electronic benefits transfer card, which is like the ATM-like card that you get public benefits on now, including food stamps. And I had asked her about that, and I said, oh yeah, people say there's less stigma, that it's more convenient, how do you feel about it? And she said, oh yeah, well, it's those things. And also, my caseworker uses it to track all of my purchases and hence all of my movements. And the question that her caseworker had actually asked her is, why are you buying all this food at the corner store? Why don't you go to the grocery store? So in fact, at least in the United States, they're already using food stamp and EBT data in exactly the way you recommend. And I will say that Dorothy did not experience that as nudging, right? She experienced that as a deep, deep violation of her dignity and a deep misunderstanding of her life, right? So her life, partially the reason she didn't go to the grocery store is the bus doesn't go to the grocery store on Sundays. And if you walk back, in her neighborhood, if you walk back with 17 bags of groceries, it's not super safe for you. So she went to the corner store because that was the best, safest, healthiest choice for her. So she experienced that very much as not only an invasion of her privacy, but also an invasion of her autonomy. And I think that's really, really important. And it comes back to this issue of consent too, which I think is really, really crucial, which is in the situation in which I do work, at least, in which I do my reporting, calling the release of this information consensual or voluntary is very problematic. It's very troubling, right? So if If you releasing this information has an impact on whether you get access to housing, food, whether or not your family gets investigated for abuse or neglect, it's hard to say that people are like freely consenting to the release of that information, right? So when we talk about data security, I actually think it's really important to always pair that with a conversation about, is the collection of the data non-coercive? So it's not just about security after you have it, it's about, did you force people to give it to you? Because that's a basic question of human dignity and democracy, and we can't build systems that don't recognize those values and aren't in line with those values.
Yeah, and I think that's a really interesting comparison. It's a very different context than what we were working in, certainly, but I mean, I wonder in that example if the person you were working with was, they knew ahead of time that data were being used for that purpose, and they just felt helpless they had to still use their card, or it was just a surprise to them to see that it was being used in that way.
It was a surprise
Yeah.
for her. She wasn't shocked as in like, this is not something I would expect from
It's
the
consistent
state.
with,
She was
yeah.
like, this is consistent with
Yeah.
my treatment. Yeah, but that's a new thing and this, by the way, it's really important. This conversation was in 1999. Right? So imagine 20 years
capacity,
later
right.
how the capacity for that has changed, and that we're not hearing about it because it doesn't affect people we see as consumers.
But it doesn't sound
Right.
to me
It's
like
really
just
important.
a security and consent issue. It's also a question of what goes into the data altogether. So that,
Yeah.
again, it's an example of where, the fact that a corner store is close and safe and a supermarket is far and unsafe is information that in principle could be in the data set. And it's not. And that's also choices, and that's the discretion moving around.
Well, it is in the data set. I mean, those data are freely available to understand where stores are located.
Well, it's in the data set, but it's not in that algorithm.
Yeah, and so I think that's a bit my point. It's how it's used to some extent. Anyway,
Yep, we should get more questions from.
You hear me?
Yeah.
Well, I love this microphone. Only at Stanford.
You going to
no
throw it
question.
at somebody, Jason?
So I have a question for John. So for the 2015 outbreak, HIV outbreak in Scott County, I just quickly Googled Scott County, and it's 97% white. Mm-hmm. And I was struck by your comment about one of the patients mentioned, what's the point of getting services? I mean, might this be the disenfranchised population that voted in 2016? So if you were to take the same data and predict out of the 220 counties that are very similar to Scott County, I bet we could go back to Margaret's moral political economy and predict what's going to happen in elections. So the data is transsectorial. It's not just epidemiology of tracking disease, but you could actually track what's going to happen politically. So I think this panel here is terrific because it goes to tell you what the data could be used for.
I didn't hear a question there, but but I appreciate the observation.
I will say that's what Nate Silver thought about the last election. And they did not do great at their predictions, right, in that case. So, yeah, there are, sometimes we build models inside of set of assumptions that are so much water to our fish that we don't even see them. And that's why we're surprised when the world doesn't affirm our models, right? And so we're like, well, how did that happen? And it's like, well, you weren't paying attention to something really like so central to our experience as human beings that we don't even see it, right? It's invisible.
But the other side of that is the kind of statistical modeling that Angus Deaton and Ann Case have been doing on the opioid crisis in the US, which wasn't meant to be predictive of who would vote how, but in retrospect actually is very correlated with who voted how, and those largely affecting white working class men.
I will raise something political, which has to do with the policy response that accompanied Scott County. The governor of Indiana at the time, Mike Pence, now the vice president, had publicly taken a position prior to the outbreak that he would never support needle exchange, that he thought needle exchange was a failed policy. And in the response, the public health officials were able to put together a strong argument based upon their use of many of the data variables that in fact that was essential in this response, and we're able to convince him. It was really the public health officials who were able to use that data to convince him that he should change that policy. And he did. And in fact, Indiana put in place a policy that said in the event of outbreaks or the recognition that something is an emergency situation, needle exchange could be put in place. Similarly, following that, in a number of different more conservative states, public health officials and others made that same case. Part of the response to the identification of those 220 counties were, you don't want this to happen here in your county and be embarrassed as you saw this happening in Indiana, you didn't respond. And it actually saw a greater openness on the part of some of those conservative governors to needle exchange, and for the first time, sort of a public acceptance that was a reasonable response. So somewhat interesting political response to that particular outbreak.
Another question? I don't know where the box
I have
is.
the teddy
There it
bear
is.
mic. I love this mic too. It makes me feel comfortable. I'm Kathy Tosas. I'm from the University of Illinois at Chicago, and my question is for Virginia. There's two short stories and then kind of the question. I'm originally from Puerto Rico.
Very
and
short.
I remember my dad one time, he has like a trailer house. He has like no teeth. The trailer house, it's like a tornado that went through it. That's why they were able to afford it. And one time he like took and put his arm around me. He took me outside and he was like, you see all of this is for you. This is your inheritance. And, his point was, this is like this tilted, a trailer house and all of this mess, but it's paid for, he owns it as his. And so it makes me think about, what is poverty and who defines it. The other story is that we work with Cuba closely, and we took a delegation of young children to Cuba, and one of the children raised his hands and he asked the tour guide, well, are you poor? And she was like, well, I have 3 pairs of shoes. You probably have 15. I have 2 lipsticks. Maybe you have 20. But my healthcare is free. I have no education debt. So no, I don't consider myself poor. And so those are the 2 stories around the relativity of being poor. And then, but my question is, you talked about not kind of clinicalizing or making poverty a pathology. So how do we change that? Because, for example, I'm an epidemiologist. We've been very successful at thinking about things like violence as an illness and making changes in that. Perhaps we should consider voting patterns as a disease, given the recent outcome of our election. So how do we change that?
Yeah, I think those 2 things are actually really deeply related to each other. And one of the things that I think is really important in the United States is shifting the language of poverty to the language of a political identity. And I think there's some great work happening around that. And the reason that's important is because social movements tend to cohere around political identities. And because we're so deeply convinced in the United States that we don't have a class system and we don't have poverty, it's that building that identity, particularly building that identity across race, is really challenging, incredibly challenging work. But I do think it's the work. And I just want to give one example of folks who are doing it. So there's an incredible organization called the Poor People's Economic Human Rights Campaign. And one of the things it's a national organization of low-income led, poor and low-income led groups that's based in Kensington and Philadelphia. And one of the things they see as part of their work is redefining poverty such that people can see themselves within the definition. So the definition they use is based on the 1948 Universal Declaration of Human Rights. It says if you're missing any one of the economic rights in the Universal Declaration, then you can sort of meaningfully count yourself among the poor. I don't want to underplay how incredibly hard that work is. It's incredibly hard. We really internalize this lesson that poverty is something that only happens to a very specific kind of person. And building that shared identity is a lot of work. But the other part of my journalist life is following poor people's movements in the United States. And I have to say, there's incredible stuff happening under the surface right now. It's not really available, I think, widely to the non-poor public, but it's out there. They're doing amazing things, and I think we're going to see huge shifts in it even in the next 5 years. So I'm actually incredibly optimistic about the possibility to move change in that area. But I think that change is around a political identity, not a disease status.
Victor, I see you with the box.
Can you hear me?
Yes.
Yes.
I thought this exchange, particularly between Virginia and David, was fabulous because it brings out some really important issues in chronic disease. We see chronic disease as I said earlier, there's social, economic, environmental, and behavioral. This exchange emphasized some of the issues because the tension, certainly in our world, is behavioral is important, but you kind of blame that person for their behavior. Social factors are important, and how do you change that? But I certainly believe, David, that actually technology will be able to help behavior in a population basis. Data, nudging is not always bad, but it could be interpreted as bad. So the question really is, how do we achieve that balance? Because I think we've done enough education. Maybe I'm exaggerating. We do a lot of talking about you should eat this, you should do that. That's just not sufficient. So it has to come down to tools that can encourage, if not nudge people to do so, recognizing at the same time that the social environmental factors are one that put them sometimes in a very difficult situation. So I'd love an interchange among you guys to see how we, public health, healthcare delivery, policymakers can move forward in achieving that balance.
Let me start. Over the last 150 years, we've seen a doubling of the lifespan. And a lot of that has been because of public health. Vaccines, clean water, sanitation, restaurant inspections, et cetera. And that was mostly because we were focused on acute and infectious disease. And now we believe, many people believe, that chronic diseases is where we have to focus over the next 50, 100 years. David said something very smart before the panel. I was hoping he'd share it during the panel. Maybe I'll put him on the spot. Maybe data is a determinant of health. We've thought about social determinants of health, but we should start to think using different frameworks. And data poverty, the absence of data around minorities. These are issues that we have to face and confront and take on if we want to actually address chronic diseases in the ways that right now the divide is getting wider. David, others?
Yeah, I think the way we were discussing it was that, and I'm not sure it's a difficult concept, but it's data about you or people like you determine in many ways what algorithms or any analytic process will infer about what's the best thing to do for you or for your situation. And so, I think it's perhaps not exactly the same as the traditional determinants of health. It's maybe more of a distortion lens, if you will, across all the other determinants of health in terms of how they're processed and people take action on them. But I think it's become such a pervasive issue that it's helpful to think about data in that way, because otherwise it becomes buried as some kind of a measurement problem. But it's pervasive. It really is. And so, I think it does illustrate a bit of the distinction between the example that you gave and the example that I gave, where the data are being sort of collected under different conditions. Different data are being collected about different people, sometimes with their knowledge and sometimes without.
About people of color. It's just not in. I'm sorry, I don't mean to interrupt. I was just about to say there's plenty of data about people of color. It's just not in the health field. It's in the criminal justice system.
Sure.
Right. So
those
the context,
inequalities and how the data are spread
matters,
out in some sense. Yeah. Anyway, that's just all I wanted to say. But I agree with you, Victor. I think that I think there is potential there, but I think we can only go. I also agree we can only go so far with technology. I think technology is very useful, but there are some fundamental basic issues that we just have to think about, as was said by Margaret and Virginia.
Maybe I could give two examples where I think it's been done well, although it's not the most complicated system, so it may fall short of actually being thought of as artificial intelligence. One that people may have heard of was linking the clinical delivery of services to the consideration of the social determinants of health and addressing issues. In New Jersey, there was an effort to try to in a particular town to do an assessment. They saw a spike in terms of the increase in terms of asthma utilization of the emergency room and hospitalizations, and couldn't explain it by the lack of health care, because the patients, in fact, were coming into care regularly that were the ones that were showing up in the emergency room. They were even being given medications and getting good care. They did an analysis looking at the way that other sectors had done data cross-analysis. They looked at geocoding of the asthma patients that had shown up in the emergency room and been hospitalized, and actually found out that the vast majority of the ones who had been hospitalized lived within 2 or 3 buildings in the same area. And when they went to the buildings, they found out, well, in fact, those buildings had a lot of mold and mildew and were really considered subpar in terms of housing conditions. And so even when people were taking their medications, there were so many triggers in their home that they were still developing the symptoms. That was not known by the clinicians. Once that became aware, then they were able to both provide home-based visits that would work on remediation of some of the conditions, but also work with the public health sector about what can you do about housing inspections so that you're able to identify those. And it's not just the people who are fortunate enough to be going to those doctors who then follow up, but that in general, no one should be living in that housing if it's disproportionately causing illness. The second example I'd give related to the question about food and apps is a positive experience where in a community health center in Massachusetts that largely served the Latino population, as the clinicians were identifying a disproportionate number of the patients who were overweight or had diabetes, they decided to in-house set up a specialized, here's what you should do to eat healthy foods, that was designed to be both economically and culturally and linguistically appropriate for the patient population. They did kind of Martha Stewart-like, here's healthy, fun cooking lessons within the health center, but in Spanish, and using as the basis of the instructions the kind of meals that people were most familiar with, and gave them tips on the ways to make those meals healthier. And then they offered them options of, there was a specialized app that was developed especially for Latino populations that allowed them, when they were shopping, to check whether or not the foods were in fact healthier, or whether there was a second option. But it was a choice. The people came in, they were offered the cooking classes, and then were offered an app. And so I thought that was an example where in fact they did find a lot of enthusiasm. I went to some of those classes. They were like standing room only, like 60 women in a room, laughing, enjoying the idea of cooking healthier foods with the foods that made their families happy, and then having a tool that they could use that was an app tool that would help them when they actually went shopping to make the decisions about the recipes.
Let me give another example, which is Code for America, which is not necessarily dealing with health, though it has improved the food stamp take-up in California and food security immeasurably. But it really gets engaged in a series of problems, and it finds a technical and algorithmic and app solution to a series of complicated problems by not just figuring out what should be done, but by actually getting engaged with the population from sort of that needs a service, whether it be legal assistance of certain kinds or clearing their records of automobile accidents or complaints in order to get jobs, or food stamp take-up, and looks at the whole chain of what's going on in the bureaucracy as well as what people's choices are in order to find the places which are bottlenecks. Mm-hmm. So it's not just creating the app and teaching people or engaging people at the level of, I love the Martha Stewart cooking example, but this is going through the whole chain and finding where there's a technological or bureaucratic hiccup that is really residual from another period and another set of problems that you can correct with a technological and sophisticated sort of usage map. So I think, again, it's got to be bringing the people in who actually need the service. I mean, I'm hearing a lot of language where it's as if we're telling them what we think they need based on our statistics, and I know that's not what's going on or the implication here. But I love the Code for America examples, which really get down in the bushes, as it were, with a demand for a particular kind of service and a solution to a particular set of problems that everyday people are experiencing.
I think we have time for one more question. Nigam is back there. He's been patient. Go ahead.
So I want to bring it back to healthcare and to machines and AI just for a little bit. There's this notion of personalized treatments that got mentioned earlier in the day, and for majority of the conversation about the use of algorithms, we need data. So, but we don't trust anybody to give them our data. And there's issues around consent as well as coercion. So how do we reconcile the need of a place to collect data, which has common trust, and our mistrust of pretty much everything, and the need to have consent without coercion? Because if I show up and I want personalized medicine, but I have not contributed my data, am I even eligible? And what is the moral argument for people to contribute data? And how do we, as a society, come to terms with at least one place where we feel safe and trusting enough to put the data? Because otherwise, all of this is just talk. I mean, it's not going to go anywhere without data.
I'm going to let Virginia answer that.
Oh, yeah, throw me the softballs. Thanks. You know what?
Good question.
It's a fantastic question, and what I want to say two things. One is I think the lack of trust that you're talking about that among people releasing their data. That's incredibly symptomatic of places that institutions have failed terribly in the past. So somebody brought up Tuskegee earlier, right? This continues to affect how African Americans interact with the medical system, absolutely beyond question, right? And so like some kind of recognition and reconciliation around acknowledging the ways that institutions have failed in the past in not accidental, but in very structured and in often intentional ways is super crucial to creating the trust that's necessary for us to actually have access to useful data across lots of different groups of people. But also, what it's coming back to, and this would have been my answer to the previous question as well, is that context just absolutely matters in every possible way, and its values all the way down, right? None of these systems are value free. So, for example, in the United States context, we criminalize poverty. And because we criminalize poverty, surveillance, or to use like a less fraught word, data collection on poor and working class communities that can offer helpful resources also acts to limit freedom, dignity, and self-determination. And that is a really terrible trade-off to force people to engage with. And I'll give you just a very quick example. So in Los Angeles, where I did work on this homeless registry, the tool they used was a really good tool of predicting who were the most vulnerable unhoused people. But then they shared that data with the police, right? And the data was things like, the questions they asked were things like, are you currently trading sex for money, right? Are you having unprotected sex? Is there an outstanding warrant open on you, right? And then that data is available to law enforcement, right? So we also have to do the political work that shifts the context in which people feel safe sharing their information. Because I don't think it's unreasonable to be suspicious about what uses your data is going to be used for in the context of the world we actually live in. Because in that context, personalization can very easily become persecution. And I think it's really crucial that we acknowledge that and move from there.
I think we're almost out of time. Is there any last thoughts from any of the panelists? And we'll have time for questions during lunch. Any last burning thoughts, Virginia?
Oh.
Just a reminder that Virginia's book is on sale at lunch.
Yeah, and I will make one plea.
And we'll all bring ours out, too.
There's a call to action to each and every one of you that we don't have the answers. We have lots of questions, that public health needs your attention. You may not get rich doing it, but you will benefit all. Thank you.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.